called MGRS, which stands for monoclonal gammopathies of renal significance, and the expanding spectrum of this disorder. Let me go to present view, okay. And the types of kidney involvement with paraproteins, brief pathophysiology, detection of paraproteins, diagnostic challenges, treatment approaches, and question and answer period. Paraproteins are monoclonal heavy chains, light chains, or intact immunoglobulins produced in excess quantities present in the blood or urine. So they're produced by a clonal B or plasma cell population. Many of you are familiar with the term MGUS, monoclonal gammopathy of unknown significance, which represents paraproteinemia without end organ damage or increased morbidity or mortality from a clone that does not meet the criteria for cancer. This is present in 3% of population about age 50. It progresses to myeloma at about 1% per year. Paraproteins have individual properties that lead to end organ damage and to different unique pictures. The kidney is commonly affected. The clone may or may not meet the criteria for cancer. When it doesn't meet the criteria for cancer, it is called monoclonal gammopathy of renal significance. If the monoclonal protein is produced by plasma cells, it often it turns out to be myeloma or will progress to myeloma over time. If it is a B cell, it may be systemic lymphoma Historically, renal paraprotein disorders have a poor renal prognosis. After the diagnosis, 50% will progress to end-stage renal disease at a rate of 2 to 5 years, regardless of whether the patient meets the criteria for cancer. The paraproteins may or may not form fibrils on electron microscopy. Non-fibril forming deposits are also termed Randall-type deposits. These disorders can recur after kidney transplant. So these paraproteins can be any one of these 5 immunoglobulins known to be synthesized and secreted by plasma cells and B cells. Obviously, IgA and IgD are extremely rare, but there are certain cases. IgG and IgA are the most common ones, and IgM is associated with Waldenstrom's macroglobulinemia, as most of you know. So the prototypical paraproteinemia is associated with multiple myeloma, which you see in this bone marrow section. And multiple myeloma is well defined as early as in 1844. So the history goes to 1844 described in a paper by Samuel Soley in June 25th. Soley presented the case of this unfortunate woman called Sarah Newberry, a 39-year-old woman, and he called this disease mollitus and fragilitas osseum, softening and breaking of bones. You can see how deformed this poor woman was. She also suffered from excruciating bone pains, and her femur in autopsy is depicted here, filled up with material and lithic lesions, and her sternum is filled up with red substance. It's called, he gave the term osteomalacia rubra fragilis for this. So if we look at the history, which spans a good 150 years, it starts with 1840, and I'll just point out some seminal events. Identification of an abnormal urine protein by Dr. Vance-Jones, which was later on called Vance-Jones protein. He did not call it Vance-Jones protein himself. It was named Vance-Jones protein by other investigators much later as a tribute for his contribution. And then we go to description of plasma cells, first large series of myeloma. A seminal finding was identification of immunoglobulin light chains as being the proteins responsible for the Vance-Jones reaction. And they are termed the kappa and lambda light chains. And then we move on to the staging system and introduction into therapy, newer agents starting with initially with melphalan and corticosteroids, and thalidomide in the 80s, bortezomib in the 1990s, lenalidomide in the 2000, and more recently monoclonal antibodies having been introduced into treatment made a significant difference in our approach to this disorder. Although I told you this disease is well defined in 1840, there is evidence that it has existed in Neolithic times. A case report from a 4,000-year-old skeletal remains in Vienna, Austria, identified myeloma, and other reports showed many other cases throughout the world, including Egyptian mummies who were CAT scanned, and additional studies were done. The point is the disease precedes modern times, and it cannot be attributed to environmental factors such as increased radiation exposure in a modern environment. The second case that was described in literature is by Dr. McIntyre, a case of a gentleman, Mr. M, since long deceased, no longer subject to HIPAA. He is known to identified as Mr. Thomas Alexander McBean, was treated by Dr. McIntyre for excruciating pains in the chest, back, and loins, and he had a strange protein in his urine, and he sent it to the Dr. Watson, a consultant, and Dr. Watson sent Dr. Jones, a well-known chemical pathologist of the time, with this letter that you can see on your screen. Dear Dr. Jones, the tube contains urine of very high specific gravity. When boiled, it becomes slightly opaque. On the addition of nitric acid, it effervesces, assumes a reddish hue, and becomes quite clear. But as it cools, assumes the consistency and appearance which you see. Heat reliquefies it. What is it? Dr. Thomas Watson. Interesting is that this case was referred by Dr. McIntyre on October 30th, and he sent the letter the following day with the sample to Dr. Jones. And Dr. Jones, after completing some studies on the specimen, concluded that this was a unique specimen of an albuminous protein. What he pointed out was that this was an unusual protein, and it should always be looked for in cases of mollitus and fragilitas of osseum. So arguably, this is the first instance of identifying a biomarker for a disease which has not failed to diagnose multiple myeloma until today. So this is Dr. Jones. And then the second breakthrough is demonstration that the protein that was responsible for the Vance-Jones reaction were unique light chains of 2 different classes, which reacted with 2 different antibodies on octolenic plates. Later on, these were and they were light chains of immunoglobulins present in myeloma patients, both in the plasma and in urine. And later on, as a tribute to Dr. Korngold and his lab technician, Rose Lipari, these light chains were named Kappa after Korngold and Lipari, Lambda after Lipari. So this is an overview of the renal disorders associated with these proteins. The myeloma could have the best known disorder is Cas nephropathy. These eosinophilic Cas, they form as a result of light chains binding to TAM protein in distal tubules, and on immunofluorescence they are monoclonal. They will react with either anti-kappa antibodies or anti-lambda antibodies. Then they can cause light chain proximal tubulopathy, cryoglobulinic glomerulonephritis, light chain deposition disease, and AL amyloidosis. So I'm going to say a few additional words on these entities, because there's some recent developments on our understanding of these disorders. So let's look at myeloma Cas nephropathy. Some investigators feel that this may not be an entirely accurate term. Perhaps it should be called myeloma kidney disease, for the reason that there is an extensive tubulointerstitial disease associated with these Cas, and in some biopsies these Cas are not visible. But in a typical case, it's very impressive. You can see these broken Cas in distal tubule, but more prominently perhaps there is tubule atrophy, some cell infiltration, and extensive interstitial fibrosis. By immunofluorescence, they will react either kappa and not react with the lambda, or vice versa. This is a case from our clinic, and as you can see, in this trichrome stain, this patient has very little Cas, but clearly extensive fibrosis, as indicated by the bluish discoloration that is a mark of fibrosis and collagen deposition in the kidney. So it's an extensive tubulointerstitial nephropathy. Indeed, this disease may present in the clinic as an insidious, slowly progressing chronic renal disease. By the time it is diagnosed, it may be too far gone. So in biopsy series, many nephropathologists pointed out to the presence of extensive inflammatory cell infiltration. And in a series reported by Dr. Herrera, a well-known nephropathologist from Shreveport, in a large series indicated that many cases had interstitial fibrosis and cell infiltration, and he called this chronic proximal tubulopathy. So clearly there is evidence of inflammation. What could be responsible for this? The Cas are rare and unpredictable, and they're usually in the distal tubule. So our laboratories looked into this in detail for many years, and I'm going to show very few studies. One of them is about when light chains are exposed to proximal tubule cells in culture. As you can see, in control cells, nuclear factor kappa B is present dormant in the cytoplasm. When exposed to light chains, they are activated and they translocate to the nucleus, which is also shown in this electrophoretic mobility shift assay gel. And when they are translocated to the nuclei, they derive the transcription of inflammatory factors, which include IL-6, IL-8, and MCP1, and they are upregulated in marked fashion. But they can be suppressed with NF-kappa B inhibitors, aspirin down to controlled levels, or PDTC, another inhibitor of NF-kappa B, again from stimulated very high levels down to controlled levels. Additionally, when cultured proximal tubule cells are exposed to light chains, the cells transform and they change phenotype. They become myofibroblasts, as can be seen here. And these cells lose their E-cadherin. At 72 hours is completely absent, and they acquire alpha-smooth muscle actin, which is a marker of myofibroblast. E-cadherin is a marker for epithelial cells. So epithelial cell characteristic is lost, and myofibroblast characteristic is increased with increasing expression of alpha-smooth muscle antibody. So more recently, we saw that light chain exposed cells also overexpress innate immunity receptors, TLR, toll-like receptors 2, 3, 4, 6, but most prominently 2, 4, and 6, which are known to play a significant role in kidney disease. This slide represents a summary of more than 2 decades collaborative work. Some of the collaborators are seen in the byline of this article, which just appeared in JCI Insight. So what happens is when light chains enter the proximal tubule cells upon filtration in the glomerulus, binding to megalin and cubilin, they downregulate TP53 BCL2, activate the reactive oxygen species, activate NF-kappa B, generate damage-associated molecular patterns, the best known of which is HMGB1, which can act as ligands for toll-like receptors and drive intense inflammation in the kidney, which could be responsible for chronic tubulointerstitial disease, which may be responsible for chronic kidney disease associated with overproduction of multiple myeloma. So other disorders associated with light chains include proximal tubule Fanconi syndrome, kappa light chain syndrome. You can see in this slide from our clinics kappa light chain staining by immunofluorescence in the cytoplasm of proximal tubule cells. In light microscopy, again, crystalline appearance within the proximal tubule cytoplasm is seen. And by electron microscopy, the crystalline characteristic of light chains is quite obvious. And there's some mitochondria here. These crystals are as big as mitochondria. And these patients often present with Fanconi syndrome associated with proximal tubular acidosis, glycosuria, and aminoaciduria. And I must point out that in an adult patient, when you see proximal tubule acidosis, the most common cause is multiple myeloma, and these patients should be investigated for the presence of multiple myeloma. So what happens then when you have a monoclonal protein in plasma and urine, but and you even may do bone marrow biopsy, but there is no myeloma? So these are called monoclonal gammopathy of renal significance. Actually, these monoclonal proteins may have organ damage outside the kidneys as well, like cardiac amyloidosis, liver amyloidosis, bladder, nerve disease, etc. So some investigators suggest an alternative term, monoclonal gammopathy of clinical significance. But my discussion is confined to monoclonal gammopathy of renal significance, which include monoclonal immunoglobulin deposition disease, light chain proximal tubulopathy, fibrillary glomerulopathy, immunotactoid glomerulopathy, proliferative glomerulonephritis with monoclonal immunoglobulin deposition, C3 glomerulonephritis with atypical hemolytic uremic syndrome, cryoglobulinemic glomerulopathy, and AL amyloidosis. Many of these diseases are not necessary to go into detail except for perhaps in a nephrology grand round. So I will very briefly show you some pictures of these. Light chain deposition disease looks like, on initial appearance, like diabetic nephropathy, the nodular glomerulosclerosis seen in diabetic nephropathy, also called Kimmel-Still-Wilson disease. Indeed, until we figured out that these deposits were caused by by light chain deposition, these were reported as diabetic kidney disease in patients who did not have diabetes. But later on, it was clarified that these were caused by nodular deposition of monoclonal light chain. This case is with kappa light chain, immunofluorescence positive for this, and along the basement membrane, these fluffy deposits are seen, and for lambda staining, it's negative. So this progresses to end-stage renal disease. Some of these cases actually also exhibit multiple myeloma as years go by. AL amyloidosis is another one associated with misfolded light chain deposition in glomeruli. The light microscopy appears like this. They are congophilic deposits. So these are amyloids that can be identified by Congo red staining. Congo red staining also allows demonstration of birefringence and fluorescence under fluorescent microscopy. And Bioimmunofluorescence is characterized by these 8 to 10 nanometer fibril deposition, and by immunofluorescence, again, monoclonality is confirmed. So they will either stain with kappa or lambda. They are most frequent with lambda, but kappa light chains can also cause amyloidosis, and other organs may also be involved. Proliferative glomerulonephritis with monoclonal IgG3 deposition has also been very recently described. It is rarely seen, and this is of interest to nephrologists, and I won't say much about this. Similarly, alpha heavy chain deposition disease is a disease very rare, but has a very bad prognosis, and you can see the glomerular destruction and deposition of dense material in the basement membrane. And C3 glomerulopathy is characterized by deposition of complement in the glomerulus, but often negative for other light chain or any other immunoglobulin deposition. The pathogenesis of this disease is a monoclonal protein activates the alternate pathway and results in deposition in the glomerulus. So they may be a circulating paraprotein behaving as what was also called at one time C3 nephritic factor, which is responsible for kidney deposition and causing kidney disease, and is characterized by these dense deposits along the glomerular basement membranes. Immunotactoid glomerulopathy may be associated with CLL, and they have these large fibrils, 50 nanomicron. Cryoglobulins show variable crystalline deposition shown in this EM picture in the range of 30 to 100 nanometer. And these organized fibrillar deposit diseases are summarized here. Amyloidosis, 8 to 10 nanometer, fibrillary glomerulonephritis, 16 to 24. Immunotactoid tubular structures are quite typical, and the cryoglobulins are much more variable. So in 2012, the term MDRS was suggested, and since then a lot of work was done. And in the most recent meeting of International Kidney and Monoclonal Gammopathy Research Group, the following approach was suggested as a consensus report. When there is a suggestion of paraproteinemia, it is very important to identify what the paraprotein is. Look for SPEP and serum immunofixation, 24-hour urine electrophoresis with immunofixation. And a breakthrough has been an accurate assay for quantitatively determining free kappa or lambda light chain in serum and urine. Other tests that can be performed are looking for urine exosomes, immunoblotting, heavy and light chain assays, laser microdissection, mass spectrometry, proteomics, which has been also very recent and important and very promising method in this field. Another tool, of course, in mass spectrometry is MALDI, and ultimately many of these cases may require kidney or other involved organ tissue biopsy. For search for the underlying clone often requires bone marrow biopsy with appropriate testing, as well as peripheral blood flow cytometry, PET scanning and CT scanning, and fluorescent in situ hybridization for CD3, 138 cells, etc. So looking for bone marrow clones, bone marrow biopsy is often very profitable. The morphology and immunostaining by FISH can be diagnostic, and flow cytometry either on the aspirate or for B and plasma cells, which is considered the gold standard by hemato-oncologists in the field. Laser mass dissection and mass spectrometry, an example is shown here. In the biopsy, when the Congo red stained field is identified here, in fluorescence, the field is demarcated, as can be seen here, and then, so to speak, zapped. So this, the tissue from the section is removed, and when it's removed, you can see the empty space left behind, and subjected to mass spectrometry analysis. The 4 specimens identified kappa light chain. So this is a most definitive diagnosis of amyloidosis in many cases, where by conventional testing, the diagnosis may not be so obvious. The technique also has identified very recently, just 2 years ago, heat shock protein, DNA JB9, as a deposit responsible for kidney disease in fibrillary glomerulonephritis, and it's a specific tissue marker. So there is increasing utility. Unfortunately, not many centers have this tool available, but Mayo Clinic and a few other commercial labs are offering this useful technique. Now, I mentioned that many of these diseases, like heavy chain deposition disease, etc., are very difficult to treat, and they have bad prognosis. But multiple new agents have been introduced during the past 2 decades. These drugs are often used in combination with steroids. It requires that the nephrologists and oncologists collaborate, as we do in our place, and monitor the response of treatment in terms of renal response. Serum creatinine and urine protein creatinine ratio, or estimating the proteinuria, is helpful. Hematologic response is very well defined, and there is agreement among oncologists on a scale which ranges from complete response to very good partial response, etc. And it can be monitored by serum kappa lambda free light chain assays, urine protein electrophoresis, and repeat flow cytometry and bone marrow biopsy. So I mentioned that monoclonal immune deposition disease has a very bad prognosis, but some investigators have attempted to use empirically bortezomib in a series of 49 patients. I'm not going to read this slide to you, but just summarize the result, that in the clonal workup of these 49 patients, 38% were monoclonal gammopathy of renal significance. They couldn't find out where the monoclonal protein was coming from. Only 10% turned out to be multiple myeloma. 2% was Waldenstrom's macroglobulinemia. Paraprotein workup showed 100% were associated with monoclonal free light chains. 91% showed hematologic response, 70% were complete or very good partial response, and the renal response per International Society of Amyloidosis criteria was better than 50%, which is much better than close to 0% with the previous treatment protocols. So the overall survival in amyloidosis by time periods, as shown in this slide, 3 time periods are compared. In red, 2000 through 2004, green, 2005 to 2009, and blue, 2010 to 2014. All patient survival probability, as you can see in the most recent time period, is markedly superior to the previous 2 time periods. And the survival is even much better in cohorts who received autologous stem cell bone marrow transplantation. And another interesting, important point is that survival correlates with our ability to efficaciously remove light chains. If we can reduce light chain burden by more than 90%, shown in the dark black curve, overall patient survival is much superior if the reduction in free light chain burden is less than 90%. In this panel, shown patient survival in cardiorenal in all patients, and kidney survival also correlates significantly. The better the light chain removal, the superior is the outcome. So this brings in mind, well, what about extracorporeal removal of light chain, thereby reducing the light chain burden? What about plasma exchange? And plasma exchange indeed has been tried for decades, and data on this are conflicting. Most comparative plasma exchange studies were conducted in pre-bortezomib era, which, as you know, made a significant difference in the prognosis of multiple myeloma or empirically treated monoclonal gammopathies attributed to plasma cell clones, and prior to our ability to quantitatively and accurately determine free light chain quantities in plasma and urine. And those who recommend plasmapheresis assign evidence grade of 2B, which is relatively weak. Also introduced recently was a dialysis technique using high molecular cutoff, which permitted efficient removal in significant quantities of light chains treatment. Initial data, clinical anecdotal data, was very promising, and 2 randomized controlled trials have been initiated. One of them is completed now, and I regret to report to you that this study that's now closed found no significant difference. The investigators, however, are not giving up on this, and they are using different configurations and different trial modes to look into this further. Incidentally, this treatment modality is not available in the US. Then another exciting area in this field is particularly directing antibodies and molecules targeting misfolding proteins. As I mentioned, amyloidosis occurs because of a unique sequence in light chains that makes them misfolded during release from endoplasmic reticulum and resistant to proteolysis, and as a result, they deposit. So an idea was suggested to create antibodies directed against these sequences responsible for misfolding, and animal experiments in initial studies have showed promising results. And an interesting drug that can achieve the same effect is doxycycline itself, which is now incorporated into treatment of some amyloidosis, including actually not only AL amyloidosis, but also transthyretin amyloidosis and cardiac amyloidosis as well. Doxycycline has been shown to bind to the amyloidogenic sequence in the misfolded protein and help its clearance. The antibody was introduced by a pharmaceutical company, which was given this designation, and showed a very promising result. and was embarked on a randomized controlled trial registered in trials.gov, which also completed now, again, unfortunately negative. So they are exploring different antibodies, perhaps with better success. So let me try to recap. Patterns of nephron injury associated with paraprotein covers a very broad spectrum. Glomerular diseases include amyloidosis, both AL amyloidosis and occasionally heavy chain amyloidosis also. Monoclonal immune deposition disease, which may be light chain deposition disease, light and heavy chain deposition disease, proliferative glomerulonephritis with monoclonal IgG3 deposition, paraprotein associated C3 glomerulopathy, and fibrillary deposit diseases, including immunotactoid glomerulonephritis, fibrillary glomerulonephritis, and cryoglobulinemia. In the proximal tubule, it can cause crystal deposition and acute tubular necrosis and acute renal failure and Fanconi syndrome. And the inflammatory effects induced by light chains through toll-like receptors and cytokines cause interstitial fibrosis and tubal atrophy and chronic destruction of the kidney disease. And interaction with light chains with TAM-horseful proteins cause CAS deposition and CAS nephropathy, and sometimes asymptomatic benzoate proteinuria. So some light chains cause severe disease, others very mild disease, some barely any disease. Why is the difference? The difference is now tracked to the variable legion of the light chain. So investigators are looking for what sequences are responsible for what disease, perhaps trying to design precision therapies for paraprotein associated diseases. So to conclude, the spectrum of renal disease associated with paraproteinemia has expanded significantly in this recently introduced entity called monoclonal gammopathy of renal significance, likely to be seen by general internists as well as nephrologists and hematologists, and perhaps with some other specialists as well. So we need to pursue and detect the paraprotein and pursue treatment of the responsible clone. We need to collaborate with hematologists and oncologists in cases of cardiac amyloidosis with our cardiologists as well. The need for standardization of the workup of management of these disorders. International Kidney and Monoclonal Gammopathy Research Group is conducting workshops on this. And we need to target the treatments. When we identify the responsible clone, we can treat plasma cells with bortezomib and with B cells with treatment like rituximab. If there is no clone identified, empirical treatment trying to target either the B cell or plasma cell, most of us feel is justified. So this is my presentation on monoclonal gammopathy of renal significance. Many of the disease associated with this disorder had bad prognosis, but newer treatments have changed the picture. And thank you for your attention. I'll try to answer